medical supervision, and we would assume that is the case in this case. The findings regarding hydroxychloroquine for hospitalized patients do not demonstrate differences in mortality, although there are lots of different studies out there, and at present WHO does not advise its use in hospitalized patients on the basis that the drug has not clearly demonstrated the benefits to those who take it. But that is then for individual clinicians to make determinations regarding the use of the drug on an off-label basis. We can only report what we see from randomized controlled trials and other observational studies, and in the end it is for national authorities to determine what the use of the drug is in their context, and it is then obviously for the use of for individual clinicians to decide on how to use that knowledge in the treatment of their patients.
Thank you very much, Dr. Ryan. And I now have a question from Gabriela Sotomayor. Gabriela, please unmute yourself and go ahead.
Hola, ¿qué tal? Good afternoon, and thank you for taking my question. I would like to know what is the forecast for Mexico at this point in the pandemic. There is an increase in the cases. This week we had more than 6,000 cases a day, and yesterday more than 7,000 in just one day. And we're concerned that many of the deaths are not taking place in hospital. So what is expected? How do you see this going? Thank you.
I think it's difficult to predict the trajectory of any epidemic in countries at the moment, but certainly Mexico now has, I think, the fifth highest COVID-19 death toll, and has had record-breaking days in the last week, recording nearly 7,000 cases on a single day, with its total cases now surpassing 250,000. Mexico at the same time is in the process of reopening, and in that period the number of cases has increased significantly. And again, this is a pattern we've seen in many other countries. Opening economies in the midst of intense community transmission can lead to an acceleration of cases. That is not unique at all to the Mexican situation. And Mexico, like other countries, is balancing the demands of communities to get back to work and to be able to earn livings with the significant risk of increased and intensified and accelerated COVID transmission. So I think from the perspective of Mexico and other countries in this situation may face increase and a continued increase in cases over time, because as I said in previous intervention today, if the virus is present, if the virus is transmitting efficiently at community level, and communities continue to mix and engage in normal activity, and public health surveillance is weak in that situation, and there's not the ability to identify cases quickly, as Maria has said, investigate quickly, if these two things don't work together in concert, and if you reach a point where the number of cases exceeds the capacity of the public health system to chase down the contacts and cases, exceeds the capacity of the health system to cope with the number of severe cases, then we're right back where we started in February and March, with systems effectively failing in the face of the pressure of the number of infected. We need to try and avoid that. And again, the question in a country the size that is Mexico and many other countries like it is to really look at the subnational level, see where the virus is under control and where continued reopening continue, to understand where your hotspots are and where you may have to slow down or reverse parts of that reopening until intensify public health surveillance, intensify communications with communities. And again, it comes down to a certain extent to trust. There must be consistent, clear messaging on risk from authorities, from leaders and others. We must be honest with our communities about the spread of the disease in our communities. We must communicate that risk appropriately, and we must give people the information they need to maintain proper social distance, to engage in proper personal hygiene, to wear masks where appropriate, and we must support our communities in doing that and consistently message that in an appropriate way. Again, it is difficult for countries, especially when the individual economic consequences to individual families are negative. If you cannot go to work and you cannot earn money and you cannot feed your family, there is a huge consequence from that, and we fully understand the pressures that people themselves are under, and we fully understand from that the pressures that governments are under. But we have to find a way to balance these two important issues. We have to find a way to balance the COVID-19 acceleration against the economic reopening, because it's very, very clear from a number of countries that opening in a situation where you have intense community transmission and weak public health response leads to a difficult situation that may push a whole country back in terms of the progress that it makes, and that is not inconsequential. And blind reopening, not associated with a careful stepwise process based on data, based on open communication, may not lead to where anybody wishes to go in any country, Mexico included.
Thank you, Dr. Ryan. The next question is on COVID and smoking, and this one comes from Jim Roop. Jim from Westwood One Radio News. Jim, please go ahead.
Oh, hi. Thank you very much. As I look at this question, though, that I typed to you, that I was happy if you would just pass it along yourself. That would have been fine, but I appreciate this. I realize this is one of those stupid questions because I think the answer is obvious, but I'll ask it anyway. The question was with COVID-19 and smoking, Her Royal Highness said that people who smoke are more likely to contract the virus and also more likely to spread it. So my question was, what's the spreading aspect of it? Is it because the virus can linger in smoke? Is it because of the exhale factor? Is it because when you smoke you don't wear a mask? And then I realize it's probably all of the above. But if I'm wrong, you can answer it. If not, then I guess, Dr. Mike, you can answer the Ebola and the DRG question. Thank you.
I can take it. Yeah, as I said, it leads to more severe disease, and that is the main cause. And that's why at the moment we know that 680 million people want to quit smoking. And we know that 400 million, that's our latest estimate, will try to stop smoking. And that's the good news. And with today's initiative, we hope that we will be successful in really helping 20 million to succeed in this. So that's actually the final estimates that we have.
Thank you very much, Dr. Kresch. I now have a question from Kai Kupferschmidt, and then we'll answer Helen's question. Kai, please go ahead.
Thanks. Actually, my question has already been asked, so let me use the chance to just ask about how the way forward is looking in terms of treatments. I mean, we obviously, have some negative results on some experimental treatments. Is it becoming clearer what the next ones are that need to be tested? Because I think we're kind of getting to that second phase.
Well, I can start, and perhaps Mike would like to supplement on this one because that's a big question that you asked, and it's a good one. What I can say is within our clinical management network and also within the R&D blueprint, you know that there's a number of therapeutics and drugs that are currently under evaluation, and those clinical trials are underway. There's a lot of small trials, and of course we have the Solidarity trial that is underway. What the clinical network is doing with R&D partners is working working with those that are carrying out those clinical trials to follow them in real time. Because many of them are small, there are possibilities that we could try to combine the data coming in from some of those studies so that we can get a quicker answer to these questions. I don't have any specifics on which one is the next one, because I think that's the trillion-dollar question here. But I think that there are a number of therapeutics that are in development that will cover different aspects of the disease, whether they are the prevention of developing more severe disease or preventing people from dying. But there are a lot that are currently underway, and there's a huge number of clinical trials. Mike, do you want to add anything to that?
No, I think you've said it all. I think the clinicians who came together last week at the research forum had essentially that same view. There are lots of existing therapies. We've seen even today more data suggesting that some existing therapies for other diseases may have some impact. I think this is important. We continue to find potential treatments in the drugs we already have, and being able to pick the best of those candidates and bring them into the Solidarity and other trials is very important. And that's why the Solidarity, Recovery and Discovery trials were designed as multi-arms. They allow us and other partners in the UK, France and other places across many countries to bring in new drugs into that armory of potential drugs. The bigger question is new molecules and new drugs that are being discovered, because they obviously have a much longer pathway to be used in humans. The advantage we have with existing drugs is that many of them have strong safety profiles and are already approved for use in other diseases, and they can be relatively easily introduced into randomized controlled trials against COVID, because we already have a strong clinical and safety profile for those drugs. Other drugs, new molecules that are developed, have to go through the whole rigor of the scientific, the safety discovery process, and it takes much longer to bring those drugs into randomized controlled trials, because they have to go through primary safety studies first, and that does slow down the process by which those molecules become available. But as Maria said, there are many of those molecules currently in development, and there are other treatments like hyperimmune globulin, which are clearly already being used in trials, and we also have monoclonal antibodies, which I think show some great hope. We've certainly used monoclonal antibodies to very good effect in Ebola in Congo, and I think they've been groundbreaking in reducing mortality. Both two monoclonal antibodies have been highly successful in reducing fatality and have transformed the way we manage Ebola as a disease in the field. So I do think there are some potential platforms, types of drugs out there that may result in a much faster cycle to get those diseases to all people who need them. But again, it's a complex area, and what we're really pleased for is the level of collaboration between institutes, between clinicians, between hospitals, between every different kind of physician, doctor, nursing organization out there. I mean, we've seen today fantastic information summarized on the neurologic impacts of these diseases. We've seen other fantastic summaries of the cardiovascular impacts, and what we're seeing, I think, is one of the fastest accelerations of knowledge of the pathophysiology and the impact of this disease, and that in itself is providing very interesting insights for what we're treating. So when we look at a drug like dexamethasone currently in trials, we can attack this virus in two ways. We can attack the virus by treating the virus, in that sense trying to use drugs that will impede the virus's capacity to hurt us, but we also can treat the impact of the virus by modulating the immune response to the virus at certain stages, which prevents our systems overreacting and dampening down inflammation. We also need to look, and there are various other interventions underway using statins and other drugs that may prevent some of the blood clotting impacts. So we either have to manage the virus itself, or treat the virus itself, or the consequences of having the virus. And there's a tremendous amount of good work underway in that. And the more we understand the disease and its impact, the more we can design treatment pathways and options to be used in future. So I'm very hopeful in terms of the levels of collaboration and the levels of innovation that are underway. And I'm very confident that we will find therapies over time. And I think it bodes well for the future of emerging diseases in general, for our ability to collectively deal with pandemics. One of the most important things in dealing with a new disease is to gain an understanding of how that virus or how that disease operates in the human body and understand how it impacts human organs, how it spreads, and how it affects the immune system. The more we understand that and the more rapidly we understand that, the more we create the space for the innovators in the pharmaceutical and the pharmacology side of things to develop the countermeasures that we need. So I'm actually, while we're desperately needing more therapies, I believe the world probably at this point could not be doing more collectively in order to develop those countermeasures that we need.
Sorry, to give it a specific example of this science solutions and solidarity, one of the things that we're looking into, and Dr. Janet Diaz mentioned this the other day, is actually trying to operate a new model of working together. And we've reached out to a number of PIs that are working on a specific therapeutic, for example, so that they can work with us on a prospective meta-analysis where they agree to share data on their individual trials, and we can actually pool this, and we do these analyses as the trials are still going, so that we are learning and that we are able to understand how these therapeutics work, so that when we need to adapt our guidance, if we need to adapt our guidance, that can be done in real time. And that's a new model of working. And again, as Mike has said, this is incredible solidarity and collaboration to be able to agree to share this as these trials are ongoing. So it's something that we are trying. It's something that we're working very hard to do, and we're very grateful for the PIs that have agreed to do this with us.
Thank you, Dr. Van Kerkhove. So we're well over the hour, and I'd like to update the numbers for Helen Branswell offline. At least that's okay, Helen. I'll be in contact with you. I'll just hand over to Dr. Tedros for any final words.
Thank you, Margaret, and thank you to all for joining, and see you on Monday. Thank you.